My name is Yilin Zhang. I'm one of the VFM faculty, and I have the great pleasure of coordinating your grand rounds. Today, I'd love to introduce Dr. Mike Hori and Dr. Greg Morlin, two of our infectious disease specialists at Valley Medical Center. Dr. Hori is the head of infectious disease here and also the co-chair of infection control, and he's been with Valley since 1993. Dr. Morlin joined our group in 2018. Today, they'll be giving a highly anticipated talk on COVID-19. We anticipate quite a few questions, so if you do have any that come up during the talk, please leave your questions in the Q&A section, and we'll leave some time at the end to go through those. So without further ado, I'll go ahead and turn the platform over to them.
Great. Thanks, Dr. Zhang, for the opportunity to be able to share some of our experiences with COVID-19. Special thanks also to Dr. Hori for letting me jump in on the front part of this talk and for including me on this journey through this pandemic. It's been kind of crazy. Also, a huge thanks to all of our staff and colleagues out there that have worked so hard with so much courage and compassion for our patients. It's been incredible working with you. So I'd like to talk a little bit about the viral pathophysiology of COVID-19 and then follow that up with some signs and symptoms and disease presentation. And then finally, allude to some epidemiology and hopefully transition to Dr. Hori's talk, which is highly anticipated, I'm sure. So emerging infections can be defined as infections that have newly appeared in the population, of course, or have existed, but are rapidly increasing in incidence and geographic area. Examples of emerging infections include the Spanish flu in 1918, pretty tragic pandemic that actually affected over 500 million people and probably killed 50 million. Others that I think we've heard of are measles, cholera, smallpox, typhoid, tuberculosis, and then in the infectious disease community, we often kind of allude to HIV as our model pandemic and measures that we took to identify it and curb it. When I think of emerging infections, I think of constant change and risk factors that actually bring about these infections. And it's typically a three-pronged approach. It's one, the evolution of the pathogen, which often happens through creating genetic diversity, and that can happen through genetic reassortment or error-prone replication that happens when the pathogen divides. In the world of microbiology, our pathogens are cells can divide very quickly. In fact, in the perfect environment, E. coli typically divides every 30 minutes. So you can imagine that with that type of change in generations, that there's a huge amount of genetic diversity. The second component to emerging infections, of course, is the human population and changes that occur there that include an older population, one that is probably immunocompromised, and the increased amount of travel that we have around our smaller world. Thirdly, a risk factor or factor into the constant change that happens in generating emerging infections is our environment. And we hear a lot of climate change, and one in the stewardship community we talk about is antimicrobial pressures. So when I think of emerging infections, there are probably 1,400 of them known. And within that 1,400, there's probably many subspecies that exist also. 60% of them are probably transmitted zoonotically, as we'll see with COVID. 5 to 10% are transmitted through the environment, and 25 to 30% are probably transmitted just from human to human. I've got a list here of some of the pandemics or epidemics we've tackled in the last 20 years. And as you can see, there's several of these that involve very common viruses such as influenza and a couple of coronaviruses, as in SARS in 2003 and MERS in 2012. So 8 months ago, there was a 62-year-old gentleman that presented to our emergency department with hypertension, diabetes, and a history of a foot infection. He presented with fever, headache, myalgias, and diarrhea, and complained of a mild cough, but had no major shortness of breath. On examination, his temperature was 38, his heart rate was 74, blood pressure 118/66, and satting approximately 98% on room air, so not tremendously sick. On chest auscultation, he had rhonchi. His white blood cell count was 5.3 with a lymphopenia of 730. And on his labs, we noted that he had some renal insufficiency with a creatinine of 2.2, and his chest x-ray showed peribronchial thickening. So in this case, what's the best description of the patient's presentation? Was it, does it sound like a common cold, some seasonal allergies, pneumonia, influenza, or is this an early case of an impending pandemic? I think you could make a case for any of the above, but this gentleman was discharged and sent home, only to find that 3 days later, he came back into the emergency department with extensive infiltrates throughout both lungs. He was admitted to the hospital and intubated for progressive hypoxemic respiratory failure. And after testing and 8 days later, getting a hold of the novel coronavirus PCR test, he proved to be positive for COVID-19. This was all occurring where in China, a couple of months kind of beforehand, there had been a rise in a serious pneumonia that was thought to be associated with a seafood market in Wuhan. And also another case similar to ours occurring in Everett by a person who had actually recently returned from Wuhan, who had developed some respiratory complications and also tested positive for this COVID-19 virus. I feature here the main transmitters of this virus, thought to be either a bat or pangolin. The fact is that the coronaviruses that we've isolated from both of these species don't entirely show or aren't entirely homologous with the one that's being spread now, but we kind of suspect that it was transmitted back and forth between these species and then transmitted to humans. It wasn't uncommon to actually see bats maybe associated with this. The bat species actually harbors over 500 different types of coronaviruses. So coronaviruses exist in several different flavors. We call them alpha, beta, gamma, and delta. Of these, the alpha and betas are probably those that are mostly associated with the human species. There are 4 that are part of the common cold that we see in maybe 20% of our patients, and we test for in our respiratory viral panel that all of us use from time to time. There are also 3 additional coronaviruses that are known as SARS, MERS, and of course the COVID-2 strain that are actually associated with much more severe disease and mortality. So SARS coronavirus 2, and a little bit of nomenclature here. The virus itself is called severe acute respiratory syndrome coronavirus 2. and the infection that it causes is COVID-19. The virus itself is basically a enveloped virus with S protein spikes on the outside of it. Inside it has a 30 kilobase single-stranded RNA or messenger RNA, whose sequence was obtained in January of 2020. This pictograph here shows the spikes on the outside of the virus that give it the appearance of having a crown, and hence the name corona. This is just another picture showing the framework of the virus with an internal RNA helix that is bound to nucleoproteins and surrounded by an envelope. And then the ever so popular spike protein that's on the surface of it, and the focus of a lot of our attention. The genome itself, as I mentioned, is about 30 kilobases and encodes about 27 proteins. When we call for a coronavirus test, what we're doing is amplifying two separate portions of this genome. The first one is in the open reading frames along the early 5' end between 1A and 1B. And the second one is towards the 3' end along the N protein, or 3' terminal, or N sequence. In the middle, or actually it's probably towards the latter 3/4, is a S sequence, or this is the popular spike protein sequence. This is a busy slide. It's just meant to kind of highlight the importance of the spike sequence and how it varies among the different species of coronaviruses. It has some similarity between the one we found in humans and the one that's found in bats and the one that's found in pangolins, but not entirely identical. Importantly, having the sequence available gives us an opportunity to model what the spike protein would look like. And this is the feature protein of all of the therapies that Mike will likely be talking about later on. There's a conserved region, which is depicted by the purple residues that is the same across most species of this virus. And then the teal portion of this is the portion of the protein that interacts with the host receptor and likely contributing to the different affinity and virulence that coronavirus 2 has for human cells. When I think of pathogenesis, I think of a two-step approach. The first is the infection phase, and this is the invasion of the body by the disease-causing agents, its multiplication and reaction by the host tissue. Secondly, which I'll get to later, is the inflammatory phase. But firstly, the infection phase for SARS-CoV-2 includes viral particles that enter the lungs through respiratory droplets and then is deposited on respiratory cells. Here, the S spikes on the surface of the virus binds to an ACE2 receptor on pneumocytes. This interaction here is thought to be the important virulent step in how the virus interacts with many different host cells. But once this attachment takes place, the virus is introduced into the cell. The envelope is unwrapped, where the messenger RNA can now be translated by host proteins. As it's translated, the viral proteins now contribute to the assembly of new viruses, and then subsequently allowed to exit and infect other cells. The host receptor, again, is the angiotensin converting enzyme 2 receptor. and I highlight the fact that it's found on multiple different multiple different sites or organs, likely contributing to some of the symptoms that we see in our patients. It's found in the nose on goblet cells, likely contributing to how this is shed or spread. As I showed a little earlier, it's found on pneumocytes, also found in the gut, and probably contributing to some of the gastrointestinal and diarrhea symptoms we see in a lot of our patients. We've seen the ACE2 receptor also on endothelial cells within blood vessels. This probably contributing to late clotting disorder we see in some of our more severe patients. Likewise, in severe patients who develop a myositis, we've seen the ACE2 receptors within some of the cardiac cells. Also in the CNS system, the olfactory neurons also possess the ACE2 receptor, and this may contribute to to how a lot of our patients with COVID-19 complain of loss of smell and taste. So the second stage to this disease is the inflammatory stage, and this is the body's process of fighting against things that harm it, such as infection, of course, by releasing chemicals, and these are cytokines that call the immune system into action. In the case of COVID-19, there are two arms of the immune system that are generally in effect or working against the infection. One is the humoral arm, and this is the generation of antibodies to quench the virus. The antibodies are produced by memory B cells or plasma cells. The second arm is the cell-mediated version of our body's immune system that actually features T cells or killer T cells that recognize cells that are infected by the virus after they've been presented through an HLA molecule. And then the killer T cell is able to program these infected cells for apoptosis or cell destruction. In the case of COVID, both of these mechanisms seem to be held in check for at least the first portion of the infection, and we don't see the viral antibodies produced until sometimes later. This has been evidenced by looking at germinal centers within lymph nodes that actually show that they're empty in patients who are infected with COVID-19, as opposed to full of memory B cells during other viral syndromes. In the case of activation of T cells, it's thought that some of the viral proteins within infected cells are able to block some of the interferon signaling to program these cells for cell death. And it doesn't happen until late, but in the meantime, what is happening is that those cells that have recognized some intruder start producing cytokines or chemokines that attract other immune cells, such as macrophages, and these in turn create or secrete other cytokines, such as IL-6, and we'll kind of talk about that later on. But these have been targets for other therapies to try to curb this kind of immune dysfunction that eventually develops in patients who are infected with COVID-19. That immune dysfunction that I'm speaking of also can progress to what we call a cytokine storm or inflammatory storm, which is depicted here by some pathology found in a lung of someone infected with COVID-19. On the left side is a normal lung that has normal lung tissue where you can expect there to be good normal gas exchange. And on the right side, which are hospitalists and intensivists probably dealing with the most, is where there's so much inflammation in the lung that these patients are becoming hypoxic because of all of the inflammation that occurs within the lung tissue. The clinical presentation for COVID-19 is generally a median age of 47 to 56 is where we generally find those people that are symptomatic. The incubation periods probably between 3 and 7 days. We say 14, and this is where we've set the quarantine to 2 weeks. People generally have fevers, fatigue, dry cough, dyspnea, and GI symptoms. The clinical spectrum can be between asymptomatic and critical. In asymptomatic, we have people that have positive nucleic acid testing but no symptoms, and this can progress from kind of a mild upper respiratory infection with some fever and fatigue to more critical and very severe symptoms that include acute respiratory distress syndrome, shock encephalopathy, and other organ damage. Laboratory findings, the more typical one would be a lymphopenia. Also, there's a renal insufficiency we often seen with elevated BUN and creatinine. AST and ALT with elevated bilirubin is not uncommon, or liver toxicity. There's increased D-dimers and inflammatory markers such as CRP and LDH. We see this elevated cytokines such as IL-6 and acute phase reactants, including like a ferritin. Procalcitonin is often low. If it's elevated, it may imply a superimposed infection. Case fatality rates for COVID-19 are somewhere around 3.4%. Compared to MERS, which was 35, SARS was 10, and influenza probably less than 0.01%. This is just quickly showing how the case fatality, though, does depend on age and how it increases in our older adults, older population. The same type of increase occurs in people with chronic medical conditions. So as people develop more chronic disease such as diabetes, heart disease, kidney disease, lung disease, their case fatality rate also goes up similarly. Quick look at some numbers. R naught is somewhere between 2 to 4. This is the reproductive number. Telling us how many people we would expect to see get infected after exposure to an index case. Again, the case fatality rate somewhere between 3.4, incubational period 4 to 14 days. In viral shedding, this seems to have been a moving target and kind of set at a median, maybe 15 days. But in severe cases, of course, the viral particles can be shed longer. We've seen it even out to a couple of months. The big question here, or what we've been able to see, is that when viral particles or RNA is present at beyond 10 days, it's probably non-viable. Transmission is through respiratory droplets. The viral infection occurs by direct or indirect contact with mucous membranes, and these can be nasal, conjunctival, or oral. Typically think that this happens within a radius of maybe 6 feet, and the length of exposure would typically be expected to be beyond 15 minutes. So person-to-person spread, of course, can be seen. Droplet spread is also part of this transmission process. We think that it's probable that fomites, urine, and fecal material can also spread this. There's community spread, asymptomatic spread, which is a big one, and airborne spread. This is a comparison between SARS, MERS, and COVID-2. SARS first came on the scene in 2013, thought that the reservoir was a civet cat, and the cases were somewhere around 8,000 with a fatality rate of 11%. And transmissibility was thought to be somewhat low. In MERS, which surfaced in 2011, a camel was thought to be the reservoir, and there were 2,500 cases and a case fatality rate of 34%, so much more virulent. But transmissibility, again, was low, unless you came in contact with a camel. For SARS-CoV-2, we don't know necessarily what the reservoir is. And the cases are staggering, up around 63 million. The case fatality rate, thankfully, may be a little lower. But what's interesting is that the transmissibility of this virus is totally different from SARS and MERS. So what are some differences then, with that in mind, to how we can control the coronavirus? So for instance, in SARS, since we knew what the reservoir was, we could cull that group of cats and take them out of the community and thus stop the spread. In COVID-19, we don't know necessarily where this is spilling over from, other than transmitted from person to person. In SARS, most of the transmission, if it did happen between individuals, it was generally in the hospital, where good protective measures could be implemented. In the case of COVID-19, there seems to be this widespread community transmission, which is what's putting a lot of us in jeopardy. In SARS, this is interesting too, in that we didn't see transmission until 24 to 36 hours after symptoms developed. So there's lack of asymptomatic spread, and thus it made it a lot easier to track people down. In COVID-19, we believe that there's an abundant asymptomatic or mild spread. This graph is kind of the take-home message that I'd like to share. And this is how the density of the virus or viral load changes over the clinical course. And we believe that there may actually be a peak in the viral load actually a couple days before people start developing symptoms. Making this group early, who is asymptomatic, a critical part in the viral transmission. This is another graph that's a little busier, but it kind of helps wrap up what I've spoken about, and that is that over time and how the clinical presentation develops, the viral gene concentration seems to be highest early and then tapers over the course of this infection. Later in this disease, probably beyond the first week, we see that the mild illness at that point transitions to severe or critical in some patients, but that this later stage of disease or the viral syndrome is probably more of an inflammatory process than it is a viral phase. So I just, when I think of treating this virus, I think of a viral phase and I think of an inflammatory phase. And in the viral phase, we're looking at agents such as remdesivir and monoclonal antibodies. And in the advanced inflammatory phase, it's probably more of a curbing the inflammatory storm as the major measure for treatment. So the numbers are staggering. I think this was from the beginning of the month, 63 million cases worldwide and close to 1.5 million deaths. In our state, 203,000 cases with 2,000 or close to 3,000 deaths. So taking measures to try to flatten this curve is what I'm going to hand this over to Mike to discuss and help us with some of the missing questions. Mike, when can we get back to a normal life?
Thanks. Easy question.
Maybe while Dr. Hori is getting his PowerPoint up and running, we can go through some of the questions that have come in. This first one for you, Dr. Morlin, you mentioned the case fatality rate of 3.4%, but the table comparing it to SARS and MERS listed the rate at about 1%.
Let's see, that was the case fatality. I'm sorry.
Yeah, I think the question might be the difference between case fatality rate and our expected true mortality rate.
Yeah, I think I don't think it's a perfect number, and it changes from population. So I think it depends on the population, and the time I put the slide together. This has been a moving target for us.
All right. Well, I think I'll take over at this point. I've been assigned the second half by myself, and we will look at testing, treatment, prevention, and vaccination. So let's talk a little bit about testing for COVID-19. This picture is our Ari's Luminex PCR machine that we actually have in our laboratory, which does our testing for us fairly rapidly when we have the reagents available for it. The Luminex machine is a demonstration of molecular testing. And with this, as Greg has pointed out, we look for portions of the genome of the virus, which are reversely transcribed into DNA and then amplified in something called a thermocycler.
I might interject just really quickly. I don't think we're able to see your slides. Are you able to try sharing screens again?
Well,
While we're troubleshooting that, let's see if any of these other questions we can try going through. There are a few questions about the vaccine, so I might hold off on those until Dr. Hori presents on those. Here's one about transmission. Can you discuss whether N95 seem warranted for any COVID care, regardless of intubation or aerosolizing procedures, given what we know now?
Yeah, actually, I was going to address that. I don't know if we can use this particular version of the screen.
Doc, we can just go from here. You'll just go from slide to slide. So I think
Okay.
That's the best I can get.
Yeah, I'm sorry about that. So I am going to address the N95 issue here shortly. We can also talk a little bit about vaccination as well. Anyway, try and catch up a little bit. There are 3 different types of tests. The molecular test looks for the DNA or the RNA of the virus. Antigen testing looks for the protein on the surface, and the antibody test actually looks for our reaction to the disease in terms of antibodies in our blood. The first 2 tests are mostly obtained through samples of the upper airway, whereas the last test is obtained through blood draw. The first 2 tests can tell us whether we have acute disease right at the moment, and the last one kind of tells us whether we have had disease in the past. So there are many variations on the themes of these particular tests at this point. Rapid point of care testing has become quite popular right now. We actually have a methodology of doing that at our hospital called the Abbott Now study, which uses isothermal amplification, but it is magnitude less sensitive than the laboratory-based RT-PCR, which is the standard at the University of Washington. There are combination tests now coming out, which not only include coronavirus, but also include influenza and RSV, as the Cepheid platform has, or the BioFire platform actually has the usual viral pathogens in our extended panels plus COVID-19. A new aspect also of testing is at-home collections. I'm reminded first of Costco actually was a fairly early one into this. For $129, you can go ahead and get a box that has something you could spit into, and you can send that off to a group called Azova, which has repurposed an RT-PCR test to use sputum, and they will send you a result back in a day. For an extra $10, you can actually get a video to figure out whether you've done it the correct test or done the test correctly. Saliva testing has become more of an interest these days. There have been some studies that suggest that it compares actually pretty favorably with the nasal pharyngeal collection of sample for PCR and antigen study testing. Some of the later studies haven't been quite so favorable, so it's sort of out to jury at the moment. There are a lot of controversies associated with testing. Which is the best source? Is it nasal pharyngeal, anterior nares, middle turbinate, saliva? Do we have to do a BL on everybody to get a good test? Tupo at the Everett Clinic believes that if you do any of these correctly, you're likely to get a decent sample, which raises the question as to whether we should actually be allowing patients to collect these at home. Is that going to be adequate? Or do we have to watch them when they do it in the clinic to make sure they do it right? The other question that comes up over and over again is the sensitivity of these tests. The PCR test is about 70% sensitive in low prevalence populations. That actually is pretty good for being able to make a decision about negative predictive value. If you make the calculations, it's less so in higher, possibly higher prevalence populations. But some people have argued that almost all these tests, including the antigen and the rapid point of care testing, actually can detect virus at the levels where it's actually transmittable. So what we really need to get a lot of tests out there so we can find the people who are actually infectious. And then the final controversy really is not a controversy, but it's just a point that we have to get out. And that is, if you're positive today, that doesn't necessarily mean you won't be positive the day or two from now. And therefore, you may not be quite sensitive to go visit grandpa or grandma next weekend just because you had a positive test today. Talking a little bit about treatment, Greg has already touched on this earlier. There are basically 4 types of treatment available, including antivirals, anti-inflammatories, antithrombotic agents, and support. Most of the antiviral agents have been drugs that have been repurposed from other types of infections. Remdesivir was actually repurposed from Ebola infections. MK4482, which is an antiviral, which like remdesivir attacks the RNA polymerase of the virus, was repurposed from influenza. We actually have this drug on a phase 2-3 study here as being able on a limited basis to our patients through our pulmonary department. Remdesivir is somewhat of a controversial drug. Early on, an ACT study done in the US suggested that it actually reduced the length of illness. Subsequent studies by the World Health Organization, such as the Solidarity trial, has suggested that it really doesn't do that much for length of illness or even mortality. The Infectious Disease Society of America, however, still supports it on the off possibility that it could get patients out of the hospital faster. MK4482 doesn't have that sort of robust data behind it as far as humans are concerned, but I can tell you that it actually works pretty well on ferrets. If you infect a ferret and treat them with this, they actually become non-infectious till they're ferrets, which would be a nice drug, and it also has the advantage of being oral. The other forms of antiviral we use don't actually work inside the virus to inhibit it, but it actually works to bind that spike protein that Greg referred to and prevent it from binding to our cells and infecting us. Bamlanivimab, we actually, once again, have this at our hospital in our emergency room. It is a single monoclonal drug, and it has to be given intravenously, and it has to really be given fairly early in the disease to be effective. And we actually targeted at a fairly small group of individuals, those who are likely to go on to develop severe disease based on their underlying conditions. So Bam is available through our emergency room, but to a fairly limited population of people. The Regeneron drug is also now available under an investigational use authorization, and it is a combination mAb compound. It's the one that President Trump did get, but there's not as much data out there for it in terms of published papers, and we've not incorporated it into our formulary just yet. Dexamethasone has been one of the success stories of the COVID era. The recovery study in Great Britain showed that it actually did significantly reduce mortality, and it's now pretty much standard of care for people who do require oxygen supplementation due to advanced pneumonia. There have been other studies which have corroborated this. There are just a plethora of other anti-inflammatory drugs. As Greg has pointed out, this is a problem associated with the late disease in an attempt to try and control the cytokine storms. EB05 is available here. It's a toll-like receptor inhibitor, and PB1046, which is a vasoactive intestinal peptide inhibitor, is also available here, again for a select small population on the basis of pulmonary evaluation here. And I don't think I have time really to talk too much about baricitinib today. So treatment also includes antithrombotics. As Greg has pointed out, this is a prothrombotic disease, both macro and a micro level, including strokes, DVT, pulmonary emboli, and heart attacks. But also it can cause microthrombosis within the lungs, which can damage tissue there. And I think one of the real success stories of being able to support these people and drive down the fatality rate, which is actually now about 10%, 10 times less than it was in the spring, is the judicious use of anticoagulants. And of course, support is very important, particularly if you're looking at somebody at home. These patients have a capacity, interestingly, and we found this out fairly early, to look really pretty good while being incredibly hypoxemic. So they could just potentially just drop dead from their hypoxemia without having a whole lot of warning. So when we see patients who have COVID now, we have a cadre of nurses who follow them by phone if they do go home. We also have a grant for oximeters that we can give to these patients, which also helps us to monitor them. And obviously, we do a pretty good job of monitoring patients in the hospital and using oxygen judiciously. Another thing that we've learned through COVID is that we can actually prone patients without using fancy rotoprone beds, and that does help their oxygenation and improve survival as well. I'll just mention this real quickly. This is a really nice little article done by John Lynch out of Harborview for mild and moderate COVID disease. And it summarizes what Greg really has already talked about, which is that there's a continuum of disease, which is based on pathophysiology, including viral replication and inflammation, which informs us as to what type of treatment, whether it's antiviral, antibody therapy, or anti-inflammatory, would be best for a patient at any given time. And with also some information with regarding to how we would want to monitor it. I think this is a really nice little summary of up-to-date data, and I would encourage you to go look at it. So let's talk a little bit about prevention right now. This is the game plan as presented by the CDC recently as we were surging, and a lot of the things as far as macro prevention within our community we already are fully aware of, including wearing masks, social distancing, avoiding gatherings, postponing travel, washing your hands, and also being protective of other people, including older people and people with underlying diseases, and then some more public health related things, including identifying, isolating cases, and doing contact tracing. And the newest part of this is now vaccinating widely, and I'll talk about that here shortly. Do any of these things actually work? This is a study out of Arizona presented by the CDC through MMWR. Arizona was lucky. They didn't get a peak in the spring like we did. You can see that they have very little in the way of cases here. And that might be due to the fact that they got on the bandwagon fairly quickly with closures of hotels, diet-in restaurants, bars, and gyms and whatnot. However, they kind of wore out in mid-May. And unfortunately, as they loosened up their restrictions, they had a marked increase up until approximately 5,000 cases per day in Arizona. So when it started going backwards, they mandated masks. That didn't seem to work. But when they started closing the bars, gyms, movie theaters, and whatnot, they started to begin to see a decline. And when they got the restaurants, they had a fairly good decline. So social distancing, as we see in these backyard of my ARMP's house, does seem to work. So let's talk about healthcare settings. This was something which people have brought up. I don't think, given the situation where we believe that this is spread by at least contact and droplet spread, that there's no discussion whether we think that gowns, gloves, and eye protection are good for our staff who are dealing with COVID patients or people under investigation. However, there continues to be controversy, even at this time, whether it's truly an airborne disease. Certainly doesn't look like measles as it used to be. It's not anywhere near as infectious as that. However, there have been plenty of studies which have shown that it can survive in droplet nuclei. So if you happen to believe that it's mostly contact droplet, you'll go along with the World Health Organization. If you believe it's truly aerosolized, airborne, you will think about using the CDC's recommendations, which are for respirators such as the N95 or cappers or pappers. So here it is. What the heck was in our head about maintaining surgical masks for as long as we have? We've been using them fairly successfully since our first case on 2/29/20, based on droplet contact spread physiology. And we've had very minimal patient to staff transmission at this hospital that we've been documenting. So we think that it has worked to date. The evidence actually presented for using N95s, if you actually look at the data, there are no head-to-head comparisons between these two things for people who do not have aerosolized generated procedure. And the evidence really is low certainty, and it's indirect, mostly from other diseases. Not all providers can fit an N95, and some of the other options that we have are somewhat limited. And N95s must be regularly changed out to maintain fitting if they're to offer any advantage over surgical masks, and maintaining the supply has been somewhat challenging. They are hard to work in, and some people really just don't want to do it. And unfortunately, do give us a false sense of security, because the patient who we know of who has COVID-19 or is a PUI might be less dangerous than some of our fellow staff members who we hang out with in the in our lounge while we're eating lunch, as in this Mayo study where they had 900 people in their staff become positive. And when they looked at it, about 93% of them were infected outside the hospital. Having said all that, we are definitely investigating stepping up our use of airborne precautions here at the hospital. Some of the challenges that we're trying to work out so we can get this out to you all are: what population should airborne be used for? I think that's a really good question. Is it just the PUIs? Is it just the people who actually we know have COVID? Or is it in the emergency room or in our respiratory clinics? Or should we be using it for all of our patients right now, given the situation that we're in right now with the surge in our community? How do we maintain a steady supply of all the different types of masks? I think you'll realize that we have 4 or 5 different masks, and I have just spent the last 2 days trying to find my particular mask on a ward. So it can be challenging to do that. How do you manage those who can't be fitted? Here's my suggestion, but I doubt I'll get much buy-in on that one. And what if you don't want to wear one? I mean, they are hard to work in. We are definitely thinking about the possibility of whether opting in to using an N95 or some other form of respirator would be a better way of going about it, if that makes you feel a little bit more comfortable, given the fact that we feel comfortable that what we've been doing has been safe up until now. So finally, the last topic: vaccines are here. But I have to remind you that vaccines don't save people, vaccinations do. Once again, just reiterate what the game plan of vaccinations are. The spike protein allows the virus to bind to our ACE2 receptors and infect us. And if we stick an antibody on that spike protein, as created in our own bodies by previous stimulation of our immunity, we can block people from getting infected, at least to the point where they don't get disease. So virtually all the vaccines, their idea is find some way to get our body to see that spike protein. And there are a couple different ways of doing it. So there's inactivated viral vaccines. These are now mostly in China. They've got at least 3 of them, which are in widespread use, either in phase 3 or actually being given to patients. The other way you can go ahead and get the spike protein into our body so that our body can recognize it and develop immunity is actually just inject it into the body straight. The paradigm of this that we know mostly of is the Shingrix vaccine that we use for shingles. Does exactly the same thing. It attaches it to an irritant or an adjuvant of some sort that stimulates our immunity. Interestingly, this Novavax vaccine is being used in phase 3 studies here at Harborview Medical Center. DNA vaccines are also there. This is kind of a switch, again, in the way we do things. Instead of actually injecting the spike protein either on dead virus or directly into our body, now we're putting in genetic material for that spike protein into our bodies, so our bodies themselves can make the spike protein, which our body can become then immune to. It needs a special device called an electroporator to do, and there isn't much study of this type of vaccine to date, but it is something which people are thinking about. Adenoviral vector vaccines are viruses that are the genetic material of the spike protein in them. And when these viruses, which are harmless, are injected into our body, they secrete the protein onto the cell surface that they can get into. And that causes us to make immunity and antibodies to that protein, which prevents disease. And the most commonly used known one right now is the Oxford AstraZeneca one, which incidentally, there's a phase 3 study for this one at Fred Hutchinson at this point. There is also a humanized adenovirus from Johnson & Johnson, which is being looked at Kaiser. This one is probably the most interesting because all the vaccines that we've been talking to so far have been 2-shot vaccines. The Johnson & Johnson is a single-shot one. And there's another combined adenoviral vaccine called Sputnik in Russia. And finally, we're down to the mRNA vaccines. Again, this is adding genetic material into our bodies, which is harmlessly broken down after it is translated into the spike protein, which then is featured on the cell surface, and we make antibody to it. It is usually adulterated in some fashion to stabilize it, and it's put into a lipid nanoparticle carrier, which must be kept very cold. These are the 2 vaccines that are currently available. As you know, the Pfizer-BioNTech vaccine was authorized last week, 95% effective against disease. It's a 2-vaccine series separated by 3 months. And again, it must be kept very cold, but it is good for 5 days after its thaw. The FDA advisory panel will review the Moderna vaccine tomorrow. 95% effective again. It's a 2-vaccine series, this time separated by 4 weeks. It doesn't have to be kept quite so cold, and it's good for 1 month once it's thawed, which should help us with our logistic challenges. This is just data from the 2 major studies that have been done for the Pfizer-BioNTech vaccine and for the Moderna vaccine. And the take-home message from this slide is they are effective and they are safe in a large number of very different types of people, both racially, ethnically, based on age span, and also what you don't see here is a variety of underlying diseases. So how are we rolling this out? This is our freezer. We actually have it here. It's -70 freezer, which is currently holding our vaccines. We're doing a tiered vaccine rollout based on potential exposure to virus and your procedural risks. And this is aligned with the University of Washington. For those who are going to be vaccinated, there will be a link provided. We would encourage you to schedule both of your vaccinations. They have to be at least 19 days apart. There's a 19 to 23 day window for scheduling that second shot. We would encourage you to do it at the end of your shift and preferably before your day off. We have an army of volunteer immunizers who will administer this in a vaccine station. You'll be given information about the vaccination, and we'll also get a survey afterwards, particularly if you have decided you didn't want it, so we can find out why. You will be able to get in the line, but it's dependent upon our availability of vaccine. So as far as adverse reactions to the vaccine, there's been much made of this. I think that virtually everybody is going to have a sore shoulder after they do this. 83% of individuals, it tends to be worse after the first vaccination, and it tends to be worse in younger individuals. But redness and swelling is actually quite a bit rarer, particularly as you compare it against this other vaccine here, Shingrix. I don't know how many have had this. This actually is the winner for adverse reactions. About half people will develop fatigue and headache associated with this, and then a variety of other minor side effects that are more systemic in nature. And most of these will go away in 24 to 48 hours. And if you look at people who volunteer adverse reactions, Shingrix is still the big time winner at 38% versus Pfizer. This is not to discourage you from getting the Shingrix vaccine, but to encourage you to get this vaccine. So who actually shouldn't get the vaccine? Well, there's very few people who shouldn't get the vaccine. People who are less than 16 years of age have not been qualified for the vaccine yet. If you've received monoclonal antibody or convalescent plasma for COVID treatment within the last 90 days, that could inhibit your immunity, and we don't recommend it. So people with severe allergies to components of the Pfizer vaccine should probably not get this vaccine at this point. People who have activating and incubating COVID infection, obviously we do not want in our vaccination clinic. So that would be it as far as that's concerned. There are some areas for caution, such as pregnancy or people with other severe underlying diseases, because we have relatively little experience with these things. But as far as we know, because it is not a live vaccine, you can still get this vaccine reasonably well. Duration of immunity is always a question. If you happen to be a rhesus macaque, we know for sure that if you were exposed to this virus 4 weeks after you get a vaccination, you will not get sick and you probably won't shed much virus. However, in humans, we don't know so much. The spike protein area is not quite as immutable as influenza proteins are, even though Greg's little picture of it did show some variation within the receptor binding site. There is robust antibody response to this vaccine up to 3 months afterwards, but in the end, we just don't know how long this vaccine's good for. Hopefully, we won't have to do it annually, and because we don't know that, we can't change our PPE policies for the foreseeable future. We continue to have to do everything we've always done before, even if you've had a vaccination. One of the things we worry about could be that you could be vaccinated and still get disease and shed it without having symptoms. Finally, as I begin to wrap up here, as we're running out of time, note of caution, the ability to reduce the spread of infection, illness, and death of any vaccination depends on more than the vaccine efficacy. And we've seen that the Moderna and the Pfizer vaccines are very effective, preventing 95% of the vaccine infection in people who have been vaccinated. But it also depends upon how quickly we get this vaccine out. It depends very much on how the vaccine is accepted. Low vaccine coverage greatly blunts the virus or the vaccine's efficacy. And, you know, other studies have been out there have shown that healthcare providers aren't necessarily jumping at this. 33% of the healthcare staff at UCLA said they would kind of wait on the sideline to see what happens to other people who get the virus before they get the vaccine before they get it. And then probably the biggest thing, which I want to point out before we finish up here, is how rapidly the virus is spreading in your community really makes a big difference as to whether the vaccine is going to be effective or not. And I can't really go through the mathematics of all, but I think that Rochelle Walensky actually pointed out the best. She'll be the head of the CDC very soon. She's out of Harvard. If you have a single fire hose, which will it be most effective on? Will it be effective on this burning building, or will it be effective on this little hut? So we want to try and get the level of disease down in our community to make the vaccine work the best. So we will continue to need to, space. We'll continue through this holiday season to encourage people not to gather, and we'll encourage people to continue using their masks and so that sort. So in the end, whether the vaccine is really going to be very helpful us depends upon how much we really want to help one another. And isn't that always been the case with COVID? And with that, I will let Dr. Morlin answer all the questions because I'm tired.
Thank you guys so much for that excellent grand rounds. We did run over, and ultimately I'll defer to you guys if you're able and have the capacity to stay to answer some questions.
Yeah.
Okay. And we'll leave if anybody who needs to go, we'll leave the chat up, and this is being recorded and we can send out a recording afterwards. So the first question, the Pfizer vaccine contains just the mRNA coding for the spike protein. Will the mRNA remain in our cells for a long time? If not,
no, the mRNA is degraded rapidly. That's all the mRNA is. We actually have mechanisms for eliminating that so we don't make endless amounts of protein that we don't need. So it's basically going to be eliminated by our natural cellular mechanism once it's actually done its job.
why have we not had pandemics with SARS and MERS?
Well, Greg?
I can answer that one. And I think it's truly the transmissibility. I think the fact, once again, that we have asymptomatic spread with COVID-2 has been a game changer. And being able to identify individuals who have the potential of transmitting it is the key to stopping those pandemics. And so that's the main difference between other corona infections and COVID-19 or COVID-2.
In a vaccinated person, what is the likelihood of transmitting virus to others?
Well, the vaccines can do two things. One, they can prevent disease, and one, they can prevent infection. And they're actually kind of two different things. I do not know much data with regard to preventing infection in people who've been vaccinated with the viral vaccines that we have currently. If you do look at macaques, although they don't shed a lot of disease, its magnitude's less than what they would have done otherwise. They do actually shed a little bit of virus, even if they've been vaccinated previously, if they're challenged with COVID. So I don't think it's going to be perfect in terms of reducing shedding the virus, but it should be quite a bit less than before, and maybe enough of a reduction to help reduce transmission.
Great. Are there any ongoing studies to determine whether vaccinated people can carry the virus? That's kind of along the same lines.
Yeah, I'm sure they're looking at this, but I don't have that data with me at the moment.
If you have a fever after the vaccination, how are we to differentiate between vaccine-related side effects versus other possible infections, such as COVID or flu?
Do you mind if I go on to a few other slides here to kind of address that problem?
Absolutely. Or we don't mind.
Okay. So here we go. Can anybody see this?
No, unfortunately.
Rats. Well, there are basically 4 buckets of side effects that we can talk about. The first bucket is the local inflammation for where you get the vaccination. That's very, 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 very unlikely to be SARS or COVID if your shoulder is sore. And so consequently, we feel like if you can work with that, then you should work and not worry too much about it. The other basket of side effects that we've heard about recently is anaphylaxis, which has been described in a couple of patients in the UK associated with this. And that's obviously going to be a fairly distinct syndrome, including shortness of breath, wheezing, swelling, urticarial rash. And, obviously the reaction to that should be you should get attention right away, including up to 911 calls. The other, let's get up here. The third bucket of side effects or of symptoms are actually not very likely to be due to the vaccine. People with fevers over 100 were less than 5% of the total population of people who got a vaccine. And cough, shortness of breath, chills, sore throat, and loss of taste and smell really had nothing to do with the vaccination. So these particular symptoms, if you should have them, just by cap and chance, by the time you've got the virus, this really doesn't change. This will work just like our fit for duty is now. You should not come to work. You should fill out the survey, and you probably should be tested. So the final group of side effects is the one that's probably the toughest to try and sort through, and that's the ones that are vague relative to both the vaccination and to COVID, and that includes, in particular, headache and fatigue, which were fairly common with this virus, but also with this vaccination, but also includes myalgias and nausea, diarrhea, and anorexia. What we're recommending for this basically right now is to watch them for about 48 hours. If there's one or less, or if there's only one of them, you probably could be okay to come to work and you don't necessarily need to be tested. However, if these particular symptoms go on for longer than 48 hours or getting worse, then you need to go back to our fit for duty algorithm and fill out a survey and probably be tested and not come to work. So that's kind of where those things work out. We think that the vast majority of our vaccinees will have mostly just local problems in the area of the vaccination and should not be mistakable for COVID. But, you know, if you have symptoms that are consistent with tier 1 symptoms, just go ahead and treat it like you would any other disease that could be COVID and get tested. And if you have these other ones, just kind of wait for a day or two and see if they get better before you start to enroll into our system. And again, we are trying to get people to go ahead and do the vaccination, you know, before a day off, just in case of these sort of problems.
Speaking of allergies, there have been several questions about contraindications to the COVID vaccines due to allergy to antibiotics, specifically penicillin and sulfa. Do we have any more information about this?
Well, the ACIP's recommendation generally has to do mostly with other vaccinations. If you've had severe reactions to other vaccinations, it's not an absolute contraindication, but it is cautionary, and they do recommend prolonged observation after you get the vaccine for as long as 30 minutes in the vaccination station before you go anywhere. So, you know, having had problems with other vaccines or other medications is not a complete contraindication to getting this particular vaccine, but you do have to plan for a longer observation period afterwards if you choose to go ahead and get the vaccination.
Are those who have previously been infected with COVID, either asymptomatic or mildly symptomatic, also encouraged to take the vaccine?
Yeah, so as far as we know, there's no reason to not get the vaccination afterwards. The vaccination in many other diseases do increase the immunity over what natural disease does. ACIP does suggest that you do take into account that your likelihood of getting reinfected in the first 90 days after an infection is low. And, you know, to some degree, you might want to let somebody else have that vaccine for the next 3 months or so for protection. So again, there's no contraindications to getting the vaccination. The only real contraindication regarding having had the infection is if you've gotten monoclonal antibody or convalescent serum, which can unfortunately bind to the spike protein that's being introduced into your body and prevent your body from creating any sort of immunity to it. So we want to try and avoid it in those situations.
What are your thoughts about what is the role for anticoagulation in the treatment of these patients? And what are your thoughts about using anticoagulation as an outpatient?
I myself don't know about that, but my thoughts are that there are no major recommendations for either dexamethasone or anticoagulation on an outpatient basis for these individuals outside of people who have known coagulopathy. As a matter of fact, dexamethasone, I just want to point out, is not indicated for ambulatory treatment. It actually can make it worse. So we do not want to use steroids on our patients who are remaining to be ambulatory who have COVID.
What does the pathway to vaccinating children look like?
They are proceeding right at this time with studies to look at children as specific subjects for this vaccination, and those are ongoing. They hope to get those out soon. I don't have a time frame, though. Obviously, children can be infected by this virus. They tended to be actually more likely to be asymptomatic than adults, although children less than 10 appear to have less likelihood of shedding the disease, shedding enough virus to infect other people. Another study showed that children 10 or greater, so 5 years into that range of people who are not getting vaccine, actually shed just as much as an adult will and cause outbreaks just as big as any adult within a household. So I think it's definitely to our benefit to try and get this under control, to know what to do with this sort of situation as far as children are concerned. But given the fact that the original studies were all adults, I don't think that anybody feels real comfortable giving them this vaccine until we know more.
How do we know if we're incubating the COVID infection and are asymptomatic, and whether or not we should get the vaccine?
If you feel fine, come and get the vaccine. The only place that might be kind of an issue would be if you know you had a high risk exposure, and that is to somebody who has active COVID-19 for 15 minutes over a 24-hour period within 6 feet. Now, obviously, being healthcare providers, many of us are in that position all the time. So I think this would have to be mostly in the household. If you found out somebody was in that sort of situation, then you might consider deferring coming in for a period of time. As a matter of fact, our employee health people might keep you from doing that, because we don't usually furlough people who've had exposures except if it's ongoing in the household. And that would probably be the only situation that I think would be of concern, is if you were undergoing ongoing exposure in your household to have somebody who has COVID right now.
Given what we do not know about previously infected patients and vaccinated patients in carriage, should we be telling households with outbreaks that they should not exit until 10 days from last known infected patient rather than 10 days from their onset of symptoms?
I need to figure out how to turn my volume up here just a little bit. Can you repeat that for me?
Given what we do not know about previously infected patients and vaccinated patients in carriage, should we be telling households with outbreaks that they should not exit until 10 days from last known infected patient rather than 10 days from their onset?
You know, I deal with these questions every single day, and for someone, I'm having a hard time unwinding that one. Do you have any idea beyond that one, Greg?
Maybe if I can restate the question, is this in a household where people have had a prior exposure, and do they still need to maintain isolation for 10 days?
And Dr. Rizzo was the one who'd asked the question initially, so if she's still on, you can clarify in the chat. Maybe we can come back to this, and if she clarifies in the chat, we can return to it. Here's another one for you, Dr. Morlin. How long does the COVID viral particle shed? And how long is the viral particle transmissible to be contagious?
Right. So we think that the viral particle that is viable actually starts to decline after the first couple of days of symptoms, and the reason why we've decided to take people out of isolation in the hospital after 10 days of mild disease is that by that point we just haven't been able to identify viable particles. So it should decline early. It all depends on the severity of a person's disease.
And then the clarification on the prior question was that there was a family outbreak that lasted over 2 months.
I think it's sort of an offline question.
Okay. I think we'll close out after this last question since we've run 15 minutes over. Thank you guys both for staying extra long to answer questions. Is there any role for the use of ivermectin or metformin?
Ivermectin is not a direct treatment of COVID. What we do worry about is individuals who have backgrounds from particularly Southeast Asia may be co-infected with Strongyloides stercoralis, and if we give them dexamethasone, they might have a hyperinfection syndrome. And so I think that's more of the problem associated with that. And honestly, to be perfectly honest, I'm not exactly sure what the parameters of that sort of treatment would be. I mean, how long have you been away from your risk country? How likely any individual who's actually had that sort of exposure would actually have that problem. We use steroids fairly commonly in patients, and we have for years without thinking too much about ivermectin. So to me, the exact population to be used for that needs a little bit more study, at least from my standpoint of view. Metformin? Oh no, Greg, what do you think?
I don't know of any study that to show that it's effective against the virus.
Okay.
Well, with that, we will conclude. Thank you, Dr. Morlin, Dr. Hori, for that excellent grand rounds. For everyone who's still on, we will be sending out a link of today's grand rounds in the leadership COVID briefing email tomorrow. So look out for that if you missed any part of it.